So the title of my talk is Impella 5.5 as a tool for pre- and post-cardiotomy syndrome. So we have heard a little bit, or not a little bit, but we heard a lot of PCCS, and with this very nice video and impressive results by Bastian. So we have different options, and here are the options we have listed in the actual guideline by the ISHLT and HFSA on how to treat these patients, and you all know that. But when we talk about PCCS and bringing patients to surgery or treat them with PCCS, we should consider that some of these devices, for example, IRBP, they do not provide a lot of cardiocirculatory support, and some of these devices listed here, they have also lung support, which can be important for patients with accompanying lung edema, for example, in left heart failure. We've seen the Impella 5.5, and again, it's an axillary approach here, and it has the advantage of mobilizing patients with a full flow device. We're talking about cardiac surgery and bringing patients to interventions and treating or preventing post-cardiotomy failure. And what is a post-cardiotomy syndrome? And there are different definitions out there. It's mostly defined by sustained hypotension, reduced cardiac index despite catecholamines, and we have already heard that inotropes and catecholamines are not the biggest fans of metabolism and in these very sick patients. And it's often inability to wean patients from cardiopulmonary bypass. But it's a heterogeneous syndrome. There are acute settings and there are chronic settings, and there are many factors that end up in patients in not being able to be weaned from cardiopulmonary bypass. And I tried a little bit to sort this out, the reasons and the different settings here. Patients with chronic ischemic cardiomyopathy, and these are data from the STA's database, they have a higher risk for mortality and morbidity, and you see it on the left, ejection fraction of below 35% or below 25%. This results in a rate of dying, almost 7.5%, stroke, and also morbidity in terms of renal failure, for example. And this is a very new analysis presented at the STS meeting. It's currently under review and will be published soon. And this is very interesting and I think also important when we talk about PCCS. They looked into patients, adult patients in the STS database with an ejection fraction below 35%. This have been patients with ischemic cardiomyopathy undergoing either CABG or CABG plus any kind of mitral valve intervention. And if you see here that in this patient cohort with low ejection fraction, PCCS in CABG patients is more than 7%, and if patients undergo CABG plus mitral, it's not because of the mitral intervention, but because of it's a surrogate for sicker patients, I guess. The hemodynamic effects, as Bastian outlined, it results in a rate of PCC of more than 16%, which is higher than I would have expected before. So it's really impressive. And I highlighted here patients with CABG and again, CABG plus mitral surgery. And once these patients experience PCCS, mortality is high. It's 30%, which is a very severe syndrome which need to be treated very carefully and with a clear plan how to do it. So what are the risks? Again, it's mitral intervention, it's reoperation, and there's the STS PROM score, the predicted risk of mortality. If this is high, also the mortality is higher, which should be expected. Patients with cardiogenic shock have high morbidity. This is nothing surprising, and patients with very low ejection fraction and already a congested liver, as seen by elevated bilirubin, they have also higher mortality, which is not surprising because the sicker patients die earlier. So how have these patients been treated? And when was the timing of MCS? Most of these patients got MCS during index surgery. Some of these patients got the MCS later. On what was this kind of MCS? We are talking about a US-based database or US database, and IRBP is still the in this setting the leading MCS device. This has many reasons, historical reasons, but also the allocation policy in the US is that patients with a short-term device, and especially IRBP, have been assigned the highest urgency for heart transplantation. And here we see mortality and morbidity based on timing of MCS device. And I would put your attention on the dark blue bars here, and we see once patients receive MCS on a later stage, so patients are leaving the OR, going to ICU, and then it is decided that patients are in need of MCS device, the higher the mortality is. And this is here for the patients with CABG plus mitral, and you see how high, it's more than 40%, how high the mortality is for these patients. And you know, we all know the scenario. Sometimes we bring these very sick patients to ICU, and we are happy to do our surgery. But on the other hand side, it's not a big party to have these patients on ICU. So I tried to elaborate a bit more that I think the preventive and early implantation of MCS devices are important. And we're going from preventing post-cardiotomy failure to treating post-cardiotomy failure. And I would give you some examples of preoperative use of bridge to surgery with Impella devices. And this 75-year-old male patient has a functional mitral regurg. He has pneumonia due to the congested lungs, and this patient has been treated by an Impella 5.5. This was actually the first patient receiving worldwide the Impella 5.5 device, and see on the right-hand side how nicely the lungs are congested. The pneumonia has been treated, and he's now a candidate to undergo mitral clip procedure after 10 days of antibiotic treatment and Impella 5.5 treatment. So this works nice to bring patients to intervention. And there is also treating post-cardiotomy failure. This is a 63-year-old male patient, status post-aortic valve replacement 10 years ago, has a deteriorated aortic valve replacement, ejection fraction of 26%, and this patient couldn't get off the heart-lung machine, and we implanted the Impella 5.5, and we couldn't go for the usual post-op workup with physiotherapy, etc., weaning and explanting of the device post-operative day 8. And so this patient has been treated by Impella 5.5 with an aortic valve replacement, with an Impella 5.5 aortic valve replacement. So going a bit more into detail in CABG patients, this study from, at that time, Heidelberg, from Wiebke Sommer and Gregor Warnecke, they looked into patients undergoing CABG surgery with simultaneous Impella implantation and with delayed Impella implantation. There have a lot of urgent and emergency procedures here. And make a long story short, again, patients receiving immediate Impella 5.5 in this very sick patient cohort had better outcomes in comparison to those receiving at the later stage in maybe not a very planned procedure, the Impella 5.5. So preventing post-cardiotomy failure is very important. And what we do in some patients, or did in the past before we included patients or enrolled these patients into the IMPACT trial, which I will talk a bit later, is that for chronic, stable ischemic cardiomyopathy with viable myocardium ejection fraction of below 30%, we did protected OPCAP surgery. As you can see here, so the heart is lifted outside the thorax, and so we can revascularize the lateral and inferior wall of the heart with stable flows of the Impella 5.0 at that time. And we looked into our first nine patients. You see patients on the right-hand side mobilized the day after surgery. Fully vascularized these patients, and a midterm outcome is excellent in these patients. So it works well. Bastian mentioned already the IMPACT trial, and this is divided into a US and an EU trial, which has some reasons because of reimbursement and market access there. But mainly it's the same protocol. So these are patients that undergo preventive implantation of the Impella 5.5. Follow-up is around 1 year. What is important, these patients undergo surgery under with the use of cardiopulmonary bypass and also cross-clamping of the aorta. Up to 123 patients are supposed to be included across European sites. And the primary endpoint is the rate of post-cardiotomy failure evaluated until discharge, and there are some safety endpoints, especially all-cause mortality and stroke up to 90 days, and some secondary endpoints which are related to the device, thromboembolic complications, for example, or morbidity, especially heart failure related, such as acute renal failure. And there was a protocol change just lastly. So what kind of procedures are included? It's CABG, it's mitral procedures, and what is new is that also aortic valve procedures are included now, and also the combination of these procedures can be included. And this is based on ejection fraction, and there are also some discussions if STS score, for example, as a surrogate for also multi-organ involvement will be included in the next protocol. And there are some exclusion criteria of those most important emergency procedures. So acute myocardial infarction, for example, is excluded, and if the patient is already in cardiogenic shock, if the patient is already on any kind of mechanical circulatory support device, such as IRPP or ECMO, and if there are any intracardiac shunts like VSD, for example, or aortic procedures such as ascending aorta replacement or arch replacement is also excluded. So far, we have included in our center 15 patients. There are the numbers, it's around 35 patients across Germany or Europe that have been included in the study, and I think it's a very interesting study, an important study for cardiac surgery because of the high risk patients have when they experience PCCS. And it's very easy to implant the Impella 5.5. You don't have to be prepared. So if your axillary artery is not draped, for example, you can use the direct aortic implantation. Bastian showed us the implant technique in his video. And the step-by-step approach, I don't want to go too much into detail in the sake of time. You can see a video also in the lunch symposium. Bastian will show it. Therefore, I will skip this for the sake of time. You can do it with fluoroscopy or without fluoroscopy. What is really important when you start also the Impella 5.5 program. The 5.5 is easy to implant, and it's important to perfectly place this pump in the left ventricle to really have good outcomes, to not experience hemolysis, and have the device in place for 30 days or even longer, which is then off-label, but 30 days for this very sick patient cohort is already good to optimize patients either to explant the device or go for LVAD implantation. And I just want to lose a word shortly on if you cannot take out your Impella device, what to do next. If we say that short-term device bridging, the gold standard here is to use an ECLS or VA ECMO. Here data from a multi-center study, at that time largest or still largest registry here, and we see that 1 year survival after LVAD implantation in ECLS bridge patients is around 50%. So the question is this really safe bridging if the outcome is 50% after that? And we have seen all these complications with ECLS. And also James Bond will agree that this is no safe bridging. So what we really need is a safe, rocket bridge. And I took this picture on one of my weekend bicycle rides. This is at the doors of Hamburg. So why is this an advantage to use an axillary Impella device over ECLS? Because we have LVAD-like conditions with a full flow axillary device. We can evaluate if the interplay between the left side and the right side works. The RV function is evaluated, patients are mobilized, and the only thing that is missing is the LVAD implantation at the very end. So we initiated together with Berlin also multi-center study to look into these results, and you see these here. It's still under review. Hopefully it's accepted soon. So 1 year survival is more than 70%, probably because of a bit of a bias, because the patients with poor right ventricles are maybe excluded here. But anyways, outcomes are around 70% or even better in Impella bridge patients. So I would like to conclude that Impella devices can be used as a bridge to surgery or interventional procedure. I showed you data on PCCS and how high mortality is. Impella devices improve survival in these high-risk patients. The preventive implantation has promising results. There are prospective studies now underway, and if the native heart function does not recover, LVAD seems to be beneficial in comparison to ECLS bridge patients. Thank you very much.